And they're getting punished for it.
You want me to sign?
Yeah, that's probably the.
Okay.
Just to
All right.
example of the insanity.
We'll launch in. We'll start. Oops. I'm Elaine Morrato, and Patty invited me to come in to share a little bit about comparative effectiveness research with you. And I'm trying to, because I know this is a mixed audience, people who are senior faculty, junior faculty, residents, that are all at a different point probably of what you're looking to get out of this. I've framed it so that the first part is more or less what is comparative effectiveness research? What is this field? What are the kinds of questions it's trying to address? And try and save then about the back half hour or so to get your questions around what are the research questions that you might have and how might I help you get points in the right direction for resources available on campus. Okay? So let me introduce myself a little bit first. I'm an associate professor in the School of Public Health in our Department of Health Systems Management Policy. I'm an epidemiologist by training. I worked for about 15 years in the pharmaceutical industry doing largely phase 3D4 kinds of studies for prescription and over-the-counter kinds of medicines. So I bring an applied angle to what I do. And I also am an investigator within the Colorado Health Outcomes and the Children's Outcomes Research Program over at the UPI building. And this is a group of investigators that come together because we're interested in measuring the ultimate outcomes of policies and procedures and practices in care. Okay. Currently, the CER, we have a core within core, which I think is how Patty actually got my name. The CCTSI is reapplying. It's resubmitting for funding, and comparative effectiveness will be a component of resources available if it's refunded and so forth. And I'll talk about that at the back end in case you're interested. Okay, so briefly I thought I'd start with what is comparative effectiveness research, how is it being described by different entities that you might have, who's funding it, NIH, Agency for Healthcare Research and Quality, and the latest is PORI, so that you understand who these funders are and how they kind of slightly view the field differently, and then your questions at the end. Okay, so how many of you have heard of the IOM report on comparative effectiveness research? Okay, you're all familiar with IOM reports, right? No? Okay, so IOM is the Institute of Medicine, and it's made up of leaders in the field of medicine, and they are often tasked with questions that are kind of cross-cutting across the field. So the area I deal with is drug safety. Several years ago, drugs were getting taken off the market. The public wasn't feeling like, gee, our regulatory system's working. The FDA asked the Institute of Medicine, please tell us, what should we be doing to protect the future of drug safety? In this case, back in 2009, do you remember what was happening in health care? That was health reform was starting to take place with the new Obama administration, and in the face of rising costs, what can we do to make sure we're using the best medicine evidence? And gee, what evidence do we have? And at that time, about half of what is done in medicine doesn't have any direct evidence for it. And so out of that, the IOM was requested, please give us, where should we prioritize the ARA, the Economic Stimulus Fund, to support this area of research? So they came out with a report in 2009 that was the first attempt to define the field. So comparative effectiveness research encompasses both the generation and synthesis of evidence. What are some examples that you're familiar with of type of research that generates new evidence in terms of methods? When you see stuff that says you should be doing this, what kind of methods are you using?
Scientific, like prospective,
trials?
retrospective.
Okay, right. Observational data that's retrospective. Do you have much prospective trials in your field?
Yes.
Yeah, randomized trials, right? Okay. So it encompasses all of that, right? So it's not just one type. Some people think of CER as that's just that observational, retrospective stuff. No, it really encompasses also doing trials, comparing. Right? What's the example? Do you have synthesis of meta-analyses in your field? Right. So that's an example of, gee, there's lots of data already out there. It just hasn't been synthesized and organized very well. Do you have Cochrane reviews, systematic reviews? Is that all in your area? All right, so Cochrane is another way of systematically going through the literature, the existing evidence, and pulling it together. So comparative effectiveness really brings all of those methodological disciplines together. And the purpose that brings them together is that they're comparing benefits and harms of alternative methods of doing healthcare. And what's important here is, you know, a lot of what we see in the medical literature focuses on the benefits of doing A or B, right? And the safety, the harms often gets underreported. And this is bringing up more of, for a patient perspective, a society's perspective, I want to know how my benefits trade off with the harms. And depending on how I value those benefits and harms from my perspective as a patient, I might view things differently. So it's not just efficacy. And it's not just thinking of it as drug A, drug B, or doing a surgery versus no surgery. It encompasses all comparisons related to prevention, comparing methods to foster immunization delivery, for example, for flu vaccination. Comparing methods of diagnostic work, which would be in your area, methods of treatment, as well as methods of monitoring, right? So it's trying to bring in all of that, not just the traditional comparisons. In addition, I think this was really big, too, is that it's comparing how we might deliver care. So accountable care organizations, right? So you've heard about the way that Grand Junction is organized, how they deliver care in the community. How might we compare that way of delivering care with more of a traditional fee-for-service or private care? It also has these broader things. And this is where the Centers for Medicaid and I think Medicare Services are interested in. What can we be doing to really transform healthcare delivery? Okay? And why is this being done? CER is being done to essentially help decisions to improve healthcare at both the individual and population level, right? So it's to help consumers, patients. It's to help clinicians like yourself. It's to help people who purchase healthcare, and it's to help policymakers know. So there are many stakeholders that are involved in it. And so I've created this schematic that's trying to show you that it's really an umbrella of research of many different methods. And that's why I want to come back at the end, because you may be more focused on a particular type of method or data set that drives a method. But really these all fit under the framework of comparative effectiveness and implementation, in which you have on the left evidence synthesis and methods and centers that are focused there. There's certain centers in the United States that are evidence-based practice centers, or Cochrane review centers, and that's where a lot of the expertise on these synthesis are ongoing. You have others that are focused on evidence generation. So on campus here, the School of Pharmacy has a strong unit that's doing observational pharmaceutical outcome studies, where you take large medical data sets or pharmacy data sets, you go back and look, and you compare people who got drug A or drug B. And we have groups that are doing practical trials. These are trials that are comparing their effectiveness trials. So when a drug or device gets approved, you'll have an efficacy trial, right? So you all know the difference between efficacy and effectiveness, I hope, right? So efficacy is saying under ideal conditions, this works better than this, and someone says, yeah, but nothing is ever under ideal conditions. These aren't the patients I see. This isn't the reality, so let's now compare it in the real world. But to do that, you have to be practical. You can't do the same rigor and control you do in an academic site that you might do if you wanted to see how two drugs are comparing out in clinical practice and so forth. And a big area, too, here is it's not just generating the evidence, but how do we more effectively disseminate and implement it into practice, so to translate it. And there are other researchers who are comparing methods of communication of that evidence. So the whole area of decision aids, patient and decision aids when you're trying to decide whether or not I should have an ICD implanted or not. when I'm trying to help encourage a patient to take their diabetes medications. So there's another line of research that's comparing those kinds of things as well, with the whole goal of outcomes, better outcomes. The other thing I think that characterizes this field is very active stakeholder engagement. I don't know, in the research that you all do in your department, how often do you have advisory boards of patients or community providers that inform what you're doing? All right. So that's a big distinction, right? Particularly in the patient-centered outcomes research, is that patients, community providers, payers, depending on your situation, are involved up front with what's the question that's important to them? What are the measures that are important to them? How might you engage them in doing the work, and then at the end, so that they see the result. Right? So it's really, by engaging them throughout the process, you should be able to better translate it into practice. So on our campus, there are folks in the CCTSI who focus on community engagement and methods there. And how do you go about that in a systematic way, not just randomly, let me just call up some patients. So those are resources I can talk about too. But out of this report came several recommendations, and this is really what's been driving the field in terms of where funding has gone the last several years. So the first one says, well, gee, if we're going to do a national CER program, we should have sufficient resources for research in the methods, and what methods are really appropriate, particularly for observational studies. So I think you said that you do retrospective chart analyses, right? You get into a lot of consideration around selection bias, of who shows up in your charts, or what diagnostics got performed. Right. So that's the big problem with observational studies, because it's reflecting which patients got channeled to which kinds of care, which kinds of diagnostics. There's a geographic variation component to all of this. And so therefore, to really do these methods well, we need to be using sort of state-of-the-art ways of adjusting for that. If we are to do clinical trials, like I said, we need to be thinking state-of-the-art and how do you make it practical. What's really the core information you need to collect, such that you're not collecting reams and reams of case report forms that never get filled out when you're trying to do this on large scale. And by large scale, these can be studies that involve tens of thousands of patients, right? So you have to simplify in order to get things done at that scale. All right. The next recommendation is this notion of large-scale clinical administrative data networks. And so they have actively funded the creation of registries focused on certain disease areas or practice types. So on campus here, there's one that's called DARTnet. And it's family medicine, practice-based research networks of communities of practices in Colorado and other states that say, we're practicing medicine, right, primary care, but we have an interest in these questions. We will work with you. Our electronic health records are such that we can bring these together to create a research database to answer questions. And that's kind of an example of engaging practices in the area of research. I don't know in radiology if there have been those kinds of national registry groups that have come together. Have they in certain topical areas?
There are registries.
There are registries.
Yeah, right. And so so what we were talking before here, what's happening is I think there's a monopolization, like oligopolies. You know, there's certain centers that are funded in certain areas. So if you want to be doing questions in that area, you almost need to get yourself attached to those kinds of centers, because now that they've been created over the last 3 years, you know, there's interest to keep them going as opposed to creating new ones. Okay. The last one here is also around this notion of needing to develop and support a workforce for CER. So out of this came special K-12 kinds of awards, institutional awards. I have one that we have here. They also have ones that were geared towards clinician physicians, and some that were geared towards specialists, surgeons, and things like that, not just primary care. And so I believe that there may have been a group here that was reapplying for that, but there have been those kinds of awards too. So as you think about K-12 institutional ones here, there is a network of folks that have been doing CER. And the last one, as I said, was stakeholder involvement recommendations. This was rather novel in that you actually have the Institute of Medicine saying you need to be fully engaging these various stakeholders at the stage of setting priorities, developing proposals, peer reviewing, and dissemination. And this is a paper that I'm involved in a comparative effectiveness within the CTSA, so all of the CCTSAs across the country. There's key function committees focused on different topics. There is one on comparative effectiveness. And within that, there's a few of us that are very interested in the how do we disseminate and implement what we find. And I'm happy to provide, if people are interested, I didn't want to download a whole bunch of stuff, but I can provide written report resources for you if you want. So just let me know. But this is a paper we published earlier this year that was just trying to give researchers a framework, a checklist, that anytime you're doing research in comparative effectiveness, you should be thinking, have you thought about who these different 7 Ps, the patient, the public, providers, purchasers, payers, policymakers, product makers? I don't know, do you get funding from manufacturers of the diagnostic equipment? Right. So, having been on the other side, we tend to, many people tend to undervalue it. I find there's a lot of really good expertise and knowledge of these products and devices that can be brought to it, as well as other principles. So it's being thoughtful as if you're designing it. It's not just what you think is really neat and cool and innovative, but have you brought in the perspective of all of the stakeholders. And lastly, the dissemination recommendation is, you've probably seen reports crossing the chasm in quality, or have heard of it. The quote is, it takes, let's see if I get it right, 17 years on average for evidence to become adopted, and only about 14% of the evidence is adopted, or something like that. So just very slow timeline to get medical evidence into practice. So if you think of the hundreds of millions of dollars being invested here, what can we be doing to get things out? And so you'll see this is actually a priority of the field, our methods in this area. So it's not just disseminating it because I got it published, but really thinking about how do I disseminate and implement it with the mind towards implementation. So that's the field. It is rather broad sounding, and there are certain funding agencies. So, and I'll go through these: NIH, ARC, and PCORI. And these are the ones that are going to have grants, right? And so we tend to focus on them because you can write grants and get funding. But I would also say that quality improvement initiatives, right? Things that you're doing locally, within the hospital, within your own patient setting, can be framed as comparative effectiveness. It's thinking of a research question that would provide information to help inform patients and providers when you're making a decision. So, doctor, why should I have this procedure, this intervention done, or this diagnostic? If I find this, what might be the outcome that I might expect? How might that outcome be related to me, given my own individual characteristics as opposed to average? So the PCORI is very much trying to provide evidence that helps with decision making. You can do this on a smaller scale in your own quality improvement as preliminary data for larger studies, right? So this is the long NIH definition. I've just highlighted a couple of things to call out. The other word that's often used with comparative effectiveness is that it's real-world studies. All right, so here we are in an academic center. Are we real-world or not? You might argue, yes, we can be real world. We have patients coming here, they're being referred, etc., and provide care. On the other hand, we tend to view things in a research-oriented way, and so our studies might take on a lot of data collection and a lot of variables that are more for us to help understand the underlying disease process or decisions the science, as opposed to just the nugget of information for a doctor or patient out in practice. So it's always to think about, well, what is really real world in your context. NIH is, it's organized by, body systems, right? And so they're very interested in the interventions. NIH is not going to go out and say, let's reorganize healthcare, right? So when they think of CER, they're thinking which intervention is most effective for which patient under which circumstance. And it's really the old RCT, but it's now framed a little bit more real world. The outcome measures are a bit more what a patient would want to know or what a doctor would want to know, right? And it's very much a focus on heterogeneity of the findings. Do you talk about that in your studies much, the heterogeneity? So how might it really vary depending on patient type, right? So not just the average patient, but it's really related to a lot of subgroup analysis. Which are the subgroups that are responders, that are not responders? Which are the, how might I drill down and say, where is this most relevant for which kind of patient group? And the type of CER they're interested in is very much trials. Secondary might be observational studies when you can't do a trial, probably. So some areas it's unethical, right? So I saw if you wanted to look at antidepressant use among prenatal care. And I'm not sure which antidepressant is safer for the baby. I'm not going to randomize moms to say, well, why don't you try, you're just not going to do it. And so you're reliant on observational studies, et cetera. And secondary data analyses of registries, okay? Agency for Healthcare Research and Quality is also interested in CER. They have a slightly different definition. They're the ones that have an interest in review of existing data. They're the ones that sponsor evidence-based practice centers in the U.S. Out of those centers come synthesis reports in different fields, and they're creating product online that you could go to. They're doing big things like lipids and diabetes that may not be really as relevant for the kind of more specialized care that you all are doing. But you can go on there to get a sense of how are they distilling the information and trying to communicate it to physicians versus patients. And ARC has a thing you can sign up for if you're into the social media stuff. It's ARC 411, right? So they're pushing out information that's supposed to help doctors change care. And they go through many of the same kinds of steps I've been talking about. Agency for Healthcare Research and Quality focuses on where do the Centers for Medicaid and Medicare Research considered priority populations as well as priority conditions. And so when you are doing work in this area, these are where their centers are focused. So you almost have to think about how your work can piggyback onto one of these topic areas. They are less funded than NIH, and really unless it's part of a center or related in this area, they are less likely to be, they're focusing on the big priority conditions. But the degree to which there's overlap with your own research interests, then there's potential there. And I can give you these health affairs. How many of you have heard of health affairs? Okay. What is health affairs?
A journal that I've heard of, and that's about all I know about.
Yeah, all right. So this is the health policy journal, right? So this is, it's not, if you're used to a science journal, that's not what you're going to find here. But you're going to find big thinkers, right? So when health reform was going through, you have a lot of opinion piece policy briefs. So if you want to see what is accountable care organizations doing, where is that going, they have really nice policy briefs that try to distill that down. It's geared towards probably policy makers, policy wonks, politician kind of audience. And so, they're focused on what are we going to do with this evidence to actually make healthcare better. They've now had a few special editions focused on comparative effectiveness I can point you. So I find it very useful because this is where the funder's strategic thinking is kind of going, and so it's useful to see those ideas, I think. And this is where where are the gaps? The gaps are evaluating reform at health system level, looking at subgroups of patients, understudied groups of patients, might be minorities or based on disease state, and then dissemination. And when you look at what came out of the stimulus funding, so the Recovery Act, most of it went to research on evidence development and infrastructure. Those were 3-year grants, and those grants are all ending now. So you have a whole bunch of researchers that have been funded who have these great centers and these great databases, and they're all trying to figure out, how do I now keep it going? And so that will be interesting. So there's momentum there. At the time, very little was being invested on translation or priority setting or stakeholder engagement, and I think that's changing a little bit. Oops, this got stuck in the middle. I apologize. This was the priorities. So IOM listed where do we need to be focusing on what kinds of questions. That's the thing. The red bars are there. The blue dots are saying, well, what got funded and overfunded. So again, if you're in a certain, this is useful to say if you're looking at sort of radiology in a certain one of these fields, you'll get a sense of what's being overfunded or underfunded in that area as well. So that was what was the stimulus. How is this going to be funded moving forward? How many have heard of PCORI? All right. What do you know about PCORI?
It's a possible funding source.
Yes. Very good. All right. So you may not know this, but one of the provisions of health reform was the creation of this non-governmental, nonprofit organization called the Patient-Centered Outcomes Research Institute. And the initial part of health reform, the government invested in it, around $40, $60 million a year. Starting in 2013, I believe, each insurer is going to be taxed a fee or whatever. They have to pay something, right? Whether it's a tax or a fee. And I think it starts out at $1 a person, $1 a covered life, and it goes to $2 a covered life, and it goes into a big pot. And this organization's job is to dole out that pot of money in this field, right? And so it's estimated that when it gets going, it may be around $600 million a year of research funding focused on comparative effectiveness. So it's very similar, but there's some slight differences. First of all, do you see what's the main word? It's patient-centered, all right? So politically, people don't want to hear I'm comparing the effectiveness of A and B because we don't have enough money, and that's why it's really money is behind the scene in the comparison. Explicit in the legislation is that they cannot look at costs or expenditures, compare costs, and this research cannot be used to give reimbursement decisions. Right, so it's very much geared more towards patient-centered and evidence that would help them make better decisions. But as you see in the definition, it's very similar to the original one from IOM, right? It's to assist patients, multiple stakeholders, right? It's to get real-world evidence. It's involving diseases, disorders, and how healthcare is delivered. So in many regards, it's how CER has been institutionalized for continued funding. This was the initial boards, so it's changing. But to give you a sense, it's led by. It's not an academic. There's only a couple academic sites, right? It's involving companies. It's involving payers and plans who are delivering care, and these are the ones that are driving how it moves forward. And a lot of the work over the last couple of years has been towards what's our priority list? What are we going to fund? And let's create some guidance for methods such that we get everyone using a similar quality of research, right? And earlier this year in May, they came out with a report on priorities for research and the research agenda. So I can send this. If you're wanting to apply for funding with that, it's a must read. And essentially they came up with 5 priority areas. They want to assess and compare prevention, diagnosis, and treatment options. They want to look at comparisons that focus on improving healthcare systems. They want to look at research that looks at improving the communication and dissemination of research. A specific area of interest is addressing disparities. So disparities is not just disparities in race, gender, It could be socioeconomic disparities. It could be disparities based on other coexisting underlying conditions, disparities, and in this whole area of research related to methods. So usually NIH does not support research on method development. So there's a real active, there's actually a methods community on here that's actively generating parallel reports on how to do things. So if you want to compete in this area, you really need to also be partnered with people who are strong methodologists and who are staying up on the literature of working with, particularly with observational data. I think when you're working with comparative or trials, we have a lot of knowledge around how to do RCTs, but this area of observational is, I think, more evolving. Okay, and so that's my 30-minute overview. And I thought what we could do now is, here's the framework. There's lots of areas that you can go after within this framework. And I thought you might have some questions that maybe we could have this more as Q&A if you have specific detailed questions around methods, or if you have resource questions, or if you have general big questions. I wanted this to be more helpful for you rather than just the lecture itself. So,
I think one of the areas you talked about patient-centered research, and typically we don't really know the patients so much. And so how would one in radiology attach themselves to someone or whatever in order to be able to make it more patient-centered and disseminate the information?
Yeah, so do you feel, well, there's nothing to stop to say that you might create your own sort of patient advice. So give me more of a specific area of radiology, and then maybe I can give an example.
I think one of the big areas, obviously, I told you earlier, was dose-related.
Right.
Trying to decide how much dose. Well, first of all, try to minimize. That's our bottom line.
Right.
As far as quality improvement, but how do we know whether the patient really cares about that?
Right. Okay. So do you have a sense of what gets communicated to them? Is currently? Yeah.
Well, we do. One thing that's been done here is the group put out a card that basically gives you the relative dose compared to some normal lifestyle events and that sort of thing. But once again, does that mean that we need a group of patients who look at that and evaluate it and say this really tells me something?
Yeah.
So that's what you're saying.
Yeah, exactly. So that card's a great example. You've developed something that's trying to make, and maybe you could first of all say, what do patients, when they're having a diagnostic procedure like that, what are the things that they're wanting to know? What do they know or don't know? So the types of methods and these probably are not methods that you necessarily have direct access to, but would want it linked to, would be qualitative research methods. I don't know. Do you all do anything in terms of in-depth interviews or patient discussions or any of those methods?
There are surveys that sometimes get filled out by patients after the fact, but it's all voluntary, I think.
Yeah, so what I would, if I were to start fresh, it would be usually you'd say, okay, let me get a couple of focus groups, so focus groups are 6 or 8 patients that come together, but you could also do them in clusters of 2 or 3. And you could put up an announcement to say, we're trying to better understand what information patients want to know when they're having these procedures, and then you run an interview discussion, and you get that learning, right? And so what we do at Coho is we have a person who's a sociologist and she's trained in doing qualitative research. She works with the clinician. Out of that comes a research study guide, and then you do the research among patients, right? And that would give insight that might then be used to refine your card. It might give insight to say, we see these different groups and we're not really sure which one is the stronger opinion. Let's do a survey, because that survey we can do with a larger number. And each one of those then becomes sort of thinking of it as a development cycle towards getting to a better card. You could also think about the reason why I was asking, who actually gives the card to the patient in your setting? Is it a nurse? Is it the doctor?
I've never seen them
Well, I think what
carry
they,
them around. They're
you
like
do
on
have
the
patient
table.
information in the waiting area for
Right.
patients to pick up, and I believe they also have pamphlets that the technologist can give to patients who ask questions.
Right.
I don't know if the patients ever really get that card. That's really was originally developed, I think, more for the clinicians.
Yeah, so then you might want to do a similar kind of interviewing with the clinicians to say, how useful is this card? How often do they use this card? Is there information that's missing on it, right? And so this kind of work is done to prepare what might be alternative ways to communicate that information you're trying to communicate, and then you would, and that could be a really PCORI-related one. I mean, there's an area that's all about communication. I think the area around ionization or things like that is probably something patients want to know. So it's and you could partner with someone that does more of communications research and say, we want to compare the effectiveness of these two different approaches of informing patients and see whether or not their opinions are different around whether or not they want to do the procedure or things like that, or have the test. Or it may be, it's overridden by, maybe they don't care about it as much, and they're overridden by, I just want to do whatever the doctor thinks is best for me to get the right image. I don't know the patient population. I know I'll give my N of 1. My father-in-law just had a series of CT, MRI, blah, blah, blah. And I don't know if they ever asked the question around that, right? So I don't know how often patients ask it, you know what I mean? So that's the touchy-feely stuff. That's the hard thing, I think, for when you're used to doing very, hard science kind of thing. How do you weave in engagement as part of that in a way that you're not having to learn those methods, but have resources that help you, right? And that's the hope, the CCTSI funding, that we would therefore be able to provide consultation or point you in direction of resources to do that. I don't know. Does that help a little bit?
I think so. I think seems like for this department it's a little difficult to try to change the patient's mind about what they want to do. I mean, I think that could be
right, exactly.
an issue with the referring physicians if you tried to get involved in that.
Right. So that may not be the.
But
you have
I don't
to.
know. I mean,
yeah.
something you have to think about.
So you have, so your audience could also be, if you're interfacing more with the physician as opposed to the ultimate patient, they're a stakeholder. So
and
you
that's
could,
acceptable if
yeah.
you don't necessarily have the patient.
Yeah. I think it's the same thing for, I'm blanking out, other physician groups in which they're not the direct access to patients, but they're going through the but you could also think about, comparing different you can make it more comparing different radiographic instruments and measures, and which ones are better. I don't know the questions that you're asking, so it's hard for me to make one up that makes sense. Yeah.
David West has said in the past, I think at least relative to AHRQ, that in comparative effectiveness studies, they want 3 comparisons. So it's not adequate to do A to B, you got to do A, B, and C. Is that true overall in your opinion, or is it unique to AHRQ and does it apply to PCORI?
Yeah, that's a good question. So I'm in David's unit, so I have to.
I know.
Yeah, I have not heard him say that, actually. He's been involved in a lot of task orders through centers, and maybe ARC was looking for that. I was one of the reviewers for PCORI in their first funding cycle, and they did not instruct us on the numbers of comparisons. It was more or less, is this comparison relevant to patients or stakeholders? How is it patient-centered in helping them address a question around their care or what they should do? And in fact, there was one application I looked at that had multiple comparisons, but I don't think it wasn't in the RFA. So, yeah, are you thinking of one in particular?
Yes. How real world is real world?
Right. Yeah. So
So, sometimes you can't execute a study in the real world for multiple valid reasons, and you have to step back from that and create an environment, a study that should have application in the real world.
Right.
But there's no way to bridge the two. One's doable, the other one isn't.
Yeah, so can you get
Sure.
an extra?
So, I'll actually plot it out here for you. We came forward with a proposal of testing the impact of ultrasound at the point of care. Anybody know how to make the screen go up?
I think
It's on that wall. It's one of those buttons.
No, it's not. No, it's behind. That's, look at that. Manual.
It's manual.
Oh,
Yeah.
oh, this is one of those high-tech ones? Nice. Seen one of those before. So, concept, how do you test point-of-care ultrasound? Does it have positive impact on patient care? Does it decrease time to correct diagnosis? Does it decrease time to appropriate therapy? Does it alleviate unnecessary diagnostic tests?
Right.
The problem with ultrasound is that it is extremely operator dependent, and education training has a huge impact on skill set. So most operator dependent imaging technique we have.
Yeah.
So we propose that we would we need a group that we can train, and most physicians are not available for that training, and weekend course is inadequate.
Yeah.
So where do you find a group of physicians that you can train up, who then would have an appropriate skill set, so then you can test those ultrasound.
So you're kind of doing a proof of concept. Right? If only we could train everybody, could we see a benefit? So let's start first with this group that we know is self-selected to want to be trained. Is that the question? Yeah.
No, exactly.
Yeah.
More or less. So, well, actually, it is getting at the potential benefit. The hypothesis that ultrasound at the point of care would have very positive impact.
Right. So the question is, are these
in skilled hands?
Right. Are these doctors generalizable? They're beyond just here in the hospital, our setting, right? They're in the community, but they've opted to want to invest time to become more
But they won't.
Okay.
It
Even
takes longer. That's the problem.
Even in your trial?
Test group.
Okay.
Medical students. All medical students. 4 years, integration, 4 years of ultrasound training. So well-developed ultrasound training program. They're the test group. So we train them up, and in the senior year we test their ability, their use of ultrasound. We take the medical students, and they examine a group of standardized patients. You're familiar with standardized patients?
Tell me more. I don't want to.
These are actors and actresses who act out a disease.
Okay.
And then the students go in, they interview them, they examine them. Yeah. They're given diagnostic tests that they ask for.
Right.
Results of tests.
Yeah.
And so this whole group of students, all of who have been trained with ultrasound, examine the same set of standardized patients.
Right.
And from that, there is a group which renders a management plan based on that encounter. There's another group that gets to, before they do that, potentially use ultrasound. And then they develop a management plan.
Okay.
So this is 50%, right?
Right.
50% over here.
Right.
Half with ultrasound, half without, even though they all know ultrasound.
Right.
So then we look at the management plan, answer 3 questions. Decrease time to diagnosis, decrease time to therapy, and 3, decrease diagnostic tests.
Right. So is the management plan a one-time thing, or you have longitudinal follow-up on it?
One-time thing.
Okay.
So you look at what are the diagnostic tests they order, how they're going to work up this patient, have they already made the correct diagnosis? And there are multiple intervention points here. You can say, do they know how to scan? You can test whether they're going to have a scan. Sure. Can they scan? Can they demonstrate?
So the decreased time to treatment and all of that is sort of, it's projected. It's estimated. It's not actual, right?
Well, yes, correct. So, did they get the diagnosis correct?
Right, but if someone says, I want to do more testing, we then say, well, on average, it takes X time to do that kind of testing. That's how
right.
Yeah.
So you could move, because you got this, you can move to that.
Yeah.
right? You don't have to send the patient somewhere else to get an ultrasound. They
So
don't
how-
get a CT,
yeah.
they don't get an MR.
So is your question how to pitch this so it might be more purported type?
Well,
work?
yeah, how do you take this sort of construct
Yeah.
and put it into a comparative effect? It is a,
Right.
you know, we are testing whether technology has a positive impact on patient care.
Right. So first of all, who generated the question?
What do you mean?
Well, the question of if only we had point of care ultrasound.
It's very common now. So technology, or ultrasound has been miniaturized over the years. Used to
Right.
be these big giant
But
carts.
who's wanting?
Now it's size of.
So is it academics that are like
No,
that
it's
are?
being disseminated
All right. So the
across all specialties already. It's really just up to the physician as to whether they think it
Right.
would be useful to them.
So has the physician said, "I'd like to know this question"? Has a patient who? Right. So
I think the healthcare enterprise needs to ask this question.
Right.
Is this cost effective? Technology is very expensive.
right.
Does this have a
Right.
worthwhile impact on healthcare?
So that would be, I think, the first one is because you would have to justify how did this research question come from stakeholders? So, you know, to what degree did you already engage a stakeholder to generate this question? It wasn't like I came up with the question and I know it will inform this stakeholder, but they were part of the synthesis. So if you could, you know, have those folks working, you probably already have, right? But have the evidence of them having commented on this, that's one thing that makes it, I think, interesting. The challenge...
But we have a lot of this, right? In medicine, we have developed technologies.
Oh, no,
that
I'm not saying it's not, yeah.
Then sold and used, which,
No, I know,
which bill now a huge cost
Right.
and
I'm just-
overhead to the practice of medicine. Right?
Yeah, I'm just looking at it from what you have for the funding. It's
Yeah.
not to say it's not
Okay.
a perfect question, because that relates to what they're looking for is more cost-effective ways of doing diagnostics, right? It's just that PCORI would want to see that to what degree did you engage whomever you're trying to get to adopt this up front, not just at the back end, right?
So the manufacturers,
Yeah, yeah,
the users,
right,
the payers potentially,
yeah, right, you know,
the patients, I mean, would all
Yeah.
potentially support
exactly,
this study.
right. So it's just having evidence of that, right, in the grant, that's, I mean, that's,
So you actually have to get evidence.
Yeah.
Go out and say
yeah,
to a group of patients, do you think it'd be better if you got your diagnostic test earlier than later? If it had positive impact on your outcome?
well, if someone's already reported, yeah, you need it, yeah. I mean, I'm just, you know, it may evolve. I just went through what they gave us as reviewers, and they want to see what is the evidence to which that you've engaged your stakeholders as part of this research enterprise, both in generating the question, the outcome measures, and in the back end on dissemination. Now, it can be as simple as you've created an advisory board, right? I mean, it doesn't have to be, you know,
Key stakeholders.
exactly. And it probably will all end up.
7 Ps.
Yeah, exactly. Yeah, I mean, it's, you know, it's not rocket science, but that would be one. And then it's probably making the case of how does this then translate to the larger question, right? So it doesn't, you know, this is a demonstration project for the larger policy relevant question, right? It's not just let's look at what med students can do. And so it's...
Well, that's the issue. So
Yeah.
here, this is an artificial environment. I mean, how
Right.
much is real life, right?
Right.
And so here we've got students, and I'm not practicing yet. They're senior.
Right.
And it's a standardized patient, so it's an
Right.
artificial environment there.
Yeah.
Right. So we're not using practicing physicians. We're not using real
Right.
patients.
It's a proof of concept that's like a small efficacy study, right? That says,
Yeah.
you know, if you can't see a benefit here, you're not going to see one out in practice, right? Is that fair to say?
Presume.
Yeah.
It sounds like, Dr. Judd, you said cost effectiveness would be an important part of this. I think you said that PCORI specifically
Right.
doesn't want to know about cost effectiveness.
Correct.
So that might
So,
be an issue.
yeah. So that's where, you know, I think the grantsmanship art is, if you were to get it funded, then can you get a separate funding to look at the cost module, right? You know, and you just break it out that way. I don't know. Is this helpful? I mean, it's kind of, it's you know,
I think it's instructive.
Yeah.
This is what we kind of do,
right.
right?
So who would fund this right now? What kind?
Nobody.
Yeah.
Industry will fund this.
Yeah.
Well, they'll supply the equipment. They may or may not fund it.
Would they fund training? Oh, they presume the training's happening as part of the medical education
They'll
process.
donate the equipment,
Yeah.
but they won't pay for the faculty for the training.
Will a health plan here in Colorado pay for this?
What's the one called? The big one?
Colorado Health Foundation or any of
Health
those?
Foundation.
Have you?
They used to, although I think they've pulled back from what they're funding.
Yeah.
So I forget what they put some restriction. They might have.
Yeah, so it may be, it may be in the framework, right? You know, if it's trying to find better ways of doing more efficient diagnostic that leads to these things faster.
Right.
And one way is this solution, but we're not sure if it's really going to do, yeah.
Right, well, and it could, I mean, you could build this, so disparities, rural health, et cetera.
Right. Yeah.
This is the dissemination, if positive, of inexpensive or less expensive technology that can be disseminated across all of the disparities, rural environments.
Right. Yeah. Yeah.
Who do you go to for cost effective?
You mean to do it or to plug something
to do
like
it.
that?
To have somebody fund it. I mean, if these guys aren't really cost effective.
You mean to fund it, not necessarily.
They could make their own.
Well,
That'd be crazy.
Then
right. This is
Equal
where,
dozen.
I have found in the pharmaceutical side that when you get like device or a product specific, it's not like a giant disease category, so it's hard to make the case. I think you could look at that's when the manufacturers might. I mean, if you've demonstrated sort of a clinical benefit, and now you just want to translate that into the cost equation, they may be willing to support that sub-study. You have existing data, you've already demonstrated utility, utilization differences, and then the question is, and so people will apply to those companies to get research grants to do that. They're usually on
Well,
the.
here, let me give you a specific example. It's not arbitrary.
Yeah.
We looked at doing appendicitis, the difference between doing CT and doing ultrasound. There's the theoretical advantage that ultrasound has non-ionizing radiation. We increased the number of ultrasounds that were performed by 150% by using ultrasound first, because since it's not ionizing, everybody will use it. Who funds a project to look at that cost effectiveness? I mean, there's a problem at some point.
Right.
Now, you may be fine if we decrease the ultrasound or decrease CT by 25% and increase our ultrasound by 500%, cost millions of dollars, you may not care.
Yeah.
Who would fund looking at that and say, it doesn't make sense to end up spending that money for a theoretical risk of radiation?
Right. Well, and it's all based on cost, not necessarily on outcomes. Can you translate it to?
Well, the outcomes are our
Already?
artificial outcomes. We know that the CT is a better test. We know it's a more accurate test.
Okay.
Better than ultrasound, without a doubt.
Yeah.
More accurate than ultrasound, without a doubt. More expensive than ultrasound.
Right.
But ultrasound is more expensive if you use it indiscriminately, which is what happens if you use it.
Has that been shown?
Yeah, we showed it.
Okay, you showed it. All right, so you've shown here. All right, now you just want to turn it into here's the cost consequence.
Well, we already know there's cost consequence, but who funds the? I mean, there's an arbitrary level at which, if it's 500 times as much, maybe that's too much. If it's twice as much, maybe that's okay.
Yeah.
So
who have you tried potential funders already?
No, I don't know who would fund that.
Is there? This is where it gets a little tricky.
You can't go to the manufacturer.
They might.
You would.
I don't know
No, they don't get care.
You would think.
Would one
With
side?
our overall cost of healthcare in the United States, we have a lot of funding to reduce that.
Right.
And there isn't any. That's what you're asking.
No, I'm not saying there isn't any. I'm just trying to think what's the easiest or most expeditious. I mean, CMS is funding things that relate to Medicaid and Medicare and transformation. They have funded over $1 billion, but they're very large kinds of projects. I mean, what you're doing is a lot smaller scale,
It's the most common cause of presentation to the emergency room in a pediatric population. It's the most common cause of emergency surgery in the abdomen in a pediatric population. There are a lot of kids in the world.
Right. So I guess that's the question. Do you have to have cost data in there to make your argument?
Cost data is the only argument against you in ultrasound.
But I thought maybe I misunderstood. I thought overuse actually leads you to more testing over. No.
It does. It's just expensive.
Yeah. So it's being overused, right?
Well, that's what the question is.
Yeah.
And the question is, at what level is that significant?
Yeah.
And who cares? I mean, it may not. Maybe nobody cares.
Cost-risk-benefit ratio.
Right. No. Yeah.
So to use ultrasound first, there's no radiation, and you're going to pick up a percentage of the appendicitis cases.
Right.
And you're going to have a slew of them that are non-diagnostic, so you're going to have to go to CT. But you prevented a small portion of the population from getting radiated, the most susceptible were kids.
Right.
But should you just say, we're not really worried about this because it costs too much, and maybe we should just start with CTs and all and be done with it?
So
that's really the basic question.
yeah.
But who? And then maybe the
Or is that risk of cancer,
expensive.
to the population just too great and unacceptable? No, you have to do ultrasound irrespective of the cost.
Okay, so it could be in that case. I'm just thinking aloud here, right? I wonder if NCI or things like, are they looking at it's the side effect of the diagnostic and those risks? Is that an angle?
It's possible.
You might have? A health system payer would be very interested in this question. So whether or not you might be able to, I'm just trying to think here in the state. Like I do work with Missouri Medicaid because they're interested in these kinds of questions and they're willing to collaborate. I don't know about Medicaid here or whether or not there's consortiums of basically the health systems and they're willing to do these kinds of research. So if you're partnered with those, they might fund something internally. Because the scale of this is more, it's a modeling exercise, right? You have all the data on how many you'll capture early versus not in numbers, right? You have that? So it's just now sort of a model exercise of what if went down this path?
The problem is that the modeling, there was a very good model.
Yeah.
Cost effectiveness. There's a Markov model, it's a terrific model.
Okay.
What happens is that the model is distorted as soon as people use ultrasound instead of CT. So that distortion changes considerably the...
Okay. Who funded that model, do you know? Yeah. So
there are some centers. There are centers for that.
Yeah.
Cost-effectiveness centers. So one of them, Scott Gazelle, has one at MGH.
Yeah.
You remember that? So he has a center for cost effectiveness.
Yeah, it's kind of being it's kind of being. Okay, I'm not trying to be flip or anything. It's kind of thinking creatively of where you can niche certain things, and part of these things are opportunistic, right? Because in general, NIH doesn't support models. You're not creating the science of models. There is an area they're doing systems modeling. So if you wanted to model like impact of this on the whole systems of care, you might be able, but you have to get partnered with people who have that kind of expertise. We could have follow-up discussion where I can think through a little bit more. It's challenging. The area of work I want to do is I want to look at FDA warnings come out and what's the impact of that on clinical care, right? Where are drugs now not being used when they should be because people are overscared? Where are what's the unintended consequence of warnings and that? It's the same kind of thing. It has huge policy relevance, but none of these agencies necessarily fund it, and the companies might if it's in their best interest. Then you're dealing with sort of conflicts and stuff. So it's often not, maybe that's not so satisfying, so. Sorry.
We're out of time. Well, thank you very much for coming in.
Okay. Yeah, part of this is conversation. Yeah, so I don't know.
No, but I like an idea.
Where?
No.
Hi.
Oh, it's
That is yogurt, yeah. But yeah.
I think in this area.
I had
Right? Yeah, it's creative.
Is that what you're gonna have for lunch?
for now it's